Listen, it's almost 1 o'clock at night, and I'm going to be a little punchy, so I'm making fun. The point is, we are going to try over the next few minutes to figure out A, how to make a clinical diagnosis, B, how to diagnose an acute fracture, C, if you can't see an acute fracture, then is it an occult fracture? Is it a no fracture? And then D and E are really, really critical because they determine the future of what happens to the scaphoid, i.e., diagnose displacement and diagnose instability, because both of these are controversial. So traditionally, we've been told that anatomic snuff box tenderness is the classic sign of a scaphoid fracture. Why is it that we go into the anatomic snuff box? Well, guess what? That's where the waist of the scaphoid is most palpable in ulnar deviation. And as we all know, the waist of the scaphoid is the most frequently fractured part of the scaphoid. So it makes sense for us to palpate in the snuff box. But what about the other areas? So you have the tubercle tenderness and the thumb compression test. And if none of these are tender, then obviously there is no fracture. But are these tests as good as we think they are? Well, let's look at the sensitivity in yellow and the specificity in blue. Anatomic snuff box tenderness and thumb compression have reasonable numbers for both sensitivity and specificity. But if you look at tubercle tenderness and pain on ulnar deviation, the specificity is all over the place. And this is based on 28 studies that's been published so far, which means that these tests are not as good for clinical diagnosis conclusively as we may want them to be. So in that being the case, Duckworth and his colleagues came up with a very nice suggestion, i.e., they said, let's see if we can predict the possibility of a fracture in someone who presents within 72 hours after their injury. So if it is a male under the age of 25 with anatomic snuff box tenderness and ulnar deviation and an injury which was sustained during sports, and they have tubercle tenderness, if they have all these four factors, then the risk of a fracture is 91%. However, the flip side was if the anatomic snuff box is non-tender on ulnar deviation, then they concluded that the risk of fracture is 0%. I mean, these are very strong numbers, but I would still say you take them with a little grain of salt because they're still guidelines. Okay, so you made the clinical diagnosis. Now what? Well, now you got to diagnose it radiographically. And traditional teaching is you got to get 4 views: the PA and lateral of the wrist, PA and ulnar deviation, and a pronation oblique 45. Now here's the kicker. If you have anatomic snuff box tenderness and you take these 4 views, up to 40% of fractures will not be seen on these 4 views, which is really concerning because everyone who walks into your office who falls off a skateboard or a scooter is not going to come into your office with such an obvious fracture. Not very uncommonly, you will see someone who comes into your office who falls off a moving treadmill. They're tender in the snuff box, and the x-rays look like this. What are we going to do next? So traditional teaching was, if the snuff box is tender but the initial x-ray is negative, then you get a follow-up x-ray in 10 to 14 days because you're looking for localized demineralization, hoping that the fracture line will be much clearer. But that's traditional teaching. We are in 2020. If you look at the published data, it really does not support that traditional teaching at all, because this methodology has poor sensitivity, poor reliability, and a poor negative predictive value. So it's not the greatest way to go about doing this, which then means that we have to look at other imaging modalities, which I call adjuvant imaging. So the most commonly used methodologies are bone scan, CT scan, and MRI scan. All of these are relatively good when it comes to sensitivity, but realistically speaking, when it comes to specificity, MRI is a little bit better than the others. So I would say that MRI is best to either rule out or rule in a fracture. Now, what does the American College of Radiology say? Well, they decided that if you have a person come into you with a wrist injury and a snuff box that's tender, but x-rays that are negative, then to decide which methodology to image them by, they made them appropriateness criteria 1 through 9, with 9 being the most appropriate and 1 being the least appropriate. And they accorded an MRI criterion number 9, which means it is the best methodology to image the scaphoid when your radiographs are negative. Let me say that again. An MRI per ACR guidelines is the best methodology to image the scaphoid in the presence of ASP tenderness and negative radiographs. The CT scan is better than a technetium scan to rule in, whereas a technetium scan is better than a CT to rule out. But none of these come without any problems. With a CT scan or a bone scan, you have radiation. On a CT scan, vascular channels may give you an appearance of a false fracture. And then again, an MRI is expensive, and not all hospitals may have its availability. But then what are the advantages of doing it? Well, you get an early diagnosis and you save the patient from being tortured with a cast or a splint. And all of those come with their own complications. Now, we seem to think that splints and casts are relatively innocuous. But guess what? They're not. Complication rates from these can be as high as 7%. In addition, the patient is stuck out of work and loss of productivity. And the MRI gives you the possibility of diagnosing other pathology as well. Now, we live in a cost-conscious world. So if you were to compare casting with 2 sets of x-rays, 2 weeks apart, loss of productivity, and then take an x-ray that's negative and MRI directly, the cost is almost exactly identical. So cost is really not something we should be thinking about when it comes to this. But at the same time, if we are going to ask for sophisticated investigations, then I think we have to be darn sure of knowing what we're asking for and how do we interpret the data that's sent back to you and not rely on the report that comes to you. So for example, when you do a CT scan, Ring and colleagues pointed out that we need to do a CT scan along the long axis of the scaphoid. If you look on the top left radiograph, the scaphoid appears reasonably well lined up when you look at it in the scaphocapitate joint. But when you get a CT along the long axis, you see that the scaphoid is really translated and there's cortical overlap, thereby suggesting that this is really a displaced fracture. On the other hand, when you look at the bottom left picture, that scaphoid to me looked initially very displaced until I got the CT. And the CT showed me that really my concerns were unfounded and the scaphoid was actually very lined up. So I utilize a CT to decide on the cortical breaks, to assess displacement, and most importantly, to assess comminution. I also use a CT to decide when the fracture is healed. When it comes to MRs, again, you have to look at T1 and T2 fat sat images, stir images, and then you're looking for something that may be entirely normal, like you see in this T2 weighted image, or you may have an obvious fracture with edema, as shown by the arrow. But then what do we do when you see edema, but no obvious fracture? Now that is debatable, and I won't go into that just yet. So going back to our lady who fell off the treadmill, here she is. These were the x-rays on day 2, and they were considered negative. Not surprisingly, the surgeon taking care of her then had x-rays done on day 14. And they were still inconclusive by their report, at which point she came to see me. And then she had an MR. And the MR was a dead giveaway with a fracture line and surrounding tremendous edema, clinching the diagnosis. Okay, so we made the diagnosis. Now the question is, what are we going to do with this? Why do we think that it's so critical to know if the fracture is displaced or not? We need to know if the fracture is displaced or not because the risk of displacement or the presence of displacement increases the risk of non-union by a factor of 2 for each 0.5 millimeter of translation. Let me repeat that. The risk of non-union is increased by a factor of 2 for each half millimeter of translation. Now let's think about this, okay? Half millimeter of translation, you cannot do that on a plain X-ray. You've got to do it on a CT scan because the assessment of displacement on a plain radiograph of 0.5 millimeters is challenging, if not entirely impossible. So then you have to look at a CT scan and you're assessing gap, translation, angulation, and rotation. But a CT scan by itself is in fact augmented when you add plain X-rays to it because the combination increases your sensitivity and a positive predictive value. So if you have a gap or a translation of more than 1 millimeter, an intrascaphoid angle of more than 35 degrees, I'm a little leery of measuring the intrascaphoid angle because it can be quite challenging. A lunate dorsal tilt on a true lateral radiograph of more than 15 degrees. And most important thing to me, which I find is what Nakamura showed us in very long ago, that the distal fragment can pronate in up to 36% patients, and you may not diagnose it, but that pronation of the distal fragment is what can give you cortical overlap in the true axial view. So let's go back. Is this fracture displaced? It doesn't look too bad on these plain radiographs. All the cortices seem to match. You get the CT, looks very promising, and then you get the lateral. And you can see the cortical overlap as well as the gapping dorsally. This cortical overlap is an outstanding example of the pronation that occurs to the distal fragment. So this was okay when we saw fractures that were displaced or semi-displaced and you got them on CT. But what do you do with a fracture that looks like this? How can you predict instability? And why are we so hung up on instability? Well, an unstable fracture portends displacement, and displacement portends lack of union. Therefore, we are always worried about instability. Now, if you look at the historical views, you have the horizontal oblique, the transverse, and the vertical oblique fractures, which Roussey gave us nearly 5 decades or 6 decades ago. And Tim Herbert came up with a more robust classification in which he gave us 2 sets of injuries, the stable acute and the unstable acute. The problem with this classification in today's day and age may be considered a little too simplistic. Why do I say that? Well, not too long ago, Bill Geisler and Joe Slade, the late Joe Slade, said that while it is reasonable to assume that displaced fractures are unstable, it is not as clear how many undisplaced fractures are unstable. And there we are left with this conundrum. What do we do with undisplaced fractures which may be unstable? We go back to CT scan and we use similar criteria as we outlined before. If you have a gap or translation of more than a millimeter, comminution or bone loss, and here's the important thing, other local fractures, i.e. the radius, lunate, triquetrum, anything. Proximal pole fractures, transcaphoid dislocations, again, lateral intrascaphoid angle of more than 35 degrees, because this increases the risk of non-union times 2 for each 0.5 millimeter of translation. But is it still as simple as we make it sound? Or is it as simple as Herbert made it sound? Herbert has been on record as saying any fracture that crosses both cortices is almost certainly unstable. Look at the choice of words. Almost certainly. That's hedging his bets, with all due respect. So then, is this fracture unstable? Well, it seems like it's going across both cortices, but in the CT scan, it seems unicortical. Well, look in this view, again, both cortices, and extends to the proximal pole. So this is a classic triplanar fracture of the scaphoid, which, because of the broad area of contact among various planes, was actually considered one of the more stable injuries and went on to heal uneventfully with about 8 weeks of casting. This, on the other hand, is someone who fell off a stage about 10 feet, has a displaced comminuted fracture of the distal radius, and a displaced comminuted fracture of the scaphoid. There is no way that you can consider this fracture to be stable. This is saying unstable to you loud and clear. And then you have something like this. You look at this fracture, it's in the proximal third, you could consider it a proximal pole. On the PA view, looks reasonable. On the oblique view, looks reasonable. Is there any reason that we should think of this as unstable? Well, think again, because that's what the CT scan shows you. So prediction of instability is still quite a conundrum as far as I'm concerned. So what are the take-home messages? If the anatomic snuff box is non-tender, fracture is unlikely. The concept of doing x-rays at 10 to 14 days is poor in terms of its predictability, its reliability, and its diagnosing capabilities. MRI, again, is the best for occult fractures or other injuries using ACR guidelines. CT is best for displacement, comminution, and assessing union. And finally, if someone can come up with a better method of prediction of instability, it'd be great, because the way it stands currently, it is extremely difficult to predict instability conclusively. Thank you.